going to turn you over. It's my pleasure to turn over the introduction of the first speaker to Alyssa Bernstein of APHA.
Thanks so much, Scott. By now, most of us are in some way familiar with the PrEP Act and the amendments that provided authorities that really optimize the role of pharmacists and the members of our pharmacy community and team during the COVID Act in providing testing, immunization, and vaccination. So our speaker, Will Chang, during much of the pandemic was Deputy General Counsel at APS. Will was a key player working with stakeholders and many of us here to identify the needs, including the barriers to access and to provision so that we can provide care to our patients. Will maneuvered through this process within the administration, within the provider community, and in the face of politics, and both at the state and the national level, and jumping some hurdles. He is a great friend of pharmacy. Will's bio is in your packet, so I won't read it, except to say that his legal experiences helped him to navigate through the process. And his current work at McKesson continues to support the profession's efforts to sustain what we attain through the PrEP Act. So I'm really pleased to welcome Will Chang.
Thank you so much, Lisa, for that kind introduction. Before I get started, I'd like to say that the views that I expressed today are those of my own and not those of McKesson or anyone else. And I also like to start by echoing what Scott said. The pharmacy community over the last 2 years have really ran into and toward the fire and not away from the fire. I want to express the gratitude from me, and I know the sincere gratitude of all my former colleagues at HHS. For the past 2 years, the response to multiple public health threats to our nation would not be nearly as successful. In fact, it would be much, much, much worse condition. But for the time, commitment, expertise, and patience of the pharmacy community, and many of those who are on this call today who spent countless hours with my teammates at HHS and with me, educating us, helping us avoid missteps, and helping us really use regulatory authorities in a way that can actually make a difference and unleash the great strength of pharmacy to support our nation's public health. I'd also like to take this opportunity to acknowledge and express my gratitude to my former colleagues at HHS, as well as the Department of Justice, who came together and realized that to be successful, we need to pull together as a nation with strong public and private partnerships, with patience and humility to listen to all those who are on the front lines, dispensing drugs, administering therapies, engaging with the patients, and working together to strengthen our country's public health one patient at a time. So thank you to those former colleagues of mine as well. The final lesson I want to start with, and just a theme that you'll hear throughout this story, is that when we work together, government and private sector alike, there is no public health crisis that we can't tackle. Just think about where we are today. In less than a year, we have FDA licensed and authorized vaccines for a novel coronavirus, the scope that we haven't seen for at least a century. And today, those vaccines are available across the nation to anyone who is medically qualified to receive them for free, all paid for. That could not have happened without the strong collaboration between public and private stakeholders. And pharmacy continues to be, and will continue to be a critical part of our nation's response of protecting public health. So with that, I'm going to start with the discussion of PrEP. And the background for this is actually something I call the tale of two viruses, or if you want to look at it differently, it's the tale of two PrEPs. Next slide, please. First one is Ready, Set, PrEP. So our tale begins on April 1st, 2019. I was new to HHS, sitting 2 doors down from the office of, from the general counsel, Rob Charo. And Bob stopped by my office one evening. I was brought on to handle litigation and investigations for the department. Public health was not in my portfolio. My background is that of a healthcare fraud prosecutor. Bob hands me a document for me to review and for my feedback on. Well, that document turns out and will eventually become the nation's first pharmaceutical large-scale donation agreement, which Gilead Pharmaceuticals would donate enough pre-exposure prophylaxis, also known as PrEP, to cover all uninsured, at-risk individuals in this country for 5 to 10 years, depending on the length of the patent. For those of you who are not as familiar with PrEP or Truvada, now Descovy, when taken correctly, which is just one oral solid, one pill a day, 365 days a year, this therapy is almost 99% effective in preventing sexually transmitted HIV. So this was a fantastic and historical accomplishment and a testament to what happens when the private sector steps up and is willing to work with the public sector to address a public health crisis, the HIV epidemic. Okay, so great news. I still recall the next day after the public announcement of this donation, which was widely covered, I get this call from CDC, and the tone of the voice was, there was some concern on the tone of the voice, and this official from the CDC asked me, hey, is CDC going to be responsible for engaging patients and distributing these drugs across the nation? And I could sense that the answer that the person calling me was hoping for was not yes. So obviously, being who I am with my personality, I said, well, I was just about to send you the UPS tracking numbers with millions of bottles of Truvada coming to the CDC parking lot. Good luck. Well, after that joke, it wasn't received very well. We set to work with a number of experts across HHS to put together the nation's first publicly funded drug distribution network to all 50 states to identify the patients and to enroll them into the Ready, Set, PrEP program, which would give Truvada and later Descovy for free. And when we were thinking about how to do it, the same message came back to us over and over again: to successfully engage this patient population, particularly with all the stigma that has historically plagued our response to this epidemic. Not only would we need mail order pharmacies, which is traditionally the vehicle by which free drugs are dispensed, in large part to control the cost of such a dispensing program and to circumvent some of the other channel costs that would be associated with a traditional dispense. We would also need brick and mortar pharmacies, and not just the chain pharmacies, but also as many settings as possible, because we need to meet patients where they are. So supermarkets, mass merchants, and very importantly, independent community pharmacies in medically underserved communities and populations that don't necessarily have other types of pharmacies. And with that, we started working with the nation's pharmacies, and they offered their expertise, they offered their patience, they offered their free dispensing services, which formed the backbone and made financially possible the Ready, Set, PrEP program. Pharmacies, both big and small, independent, regional, and national, stepped up to offer their brick and mortar dispensing services, their mail order dispensing services, as well as their counseling and adherence programs to support the Ready, Set, PrEP program. That was launched in December. So now we move forward. We're at December. We have this program that is running fairly well with the support of all these volunteering pharmacies. The general counsel then stops by between Christmas and New Year's and asks me, hey, Will, in your legal portfolio, you can go back to your day job now, which is to handle litigation investigations. Are you interested in taking on some additional portfolios? Look, they're really sleepy ones. This is the public health portfolio. Historically, they're very science driven. They give out grants, they monitor for diseases. It wouldn't be that much extra work. I'm like, okay, Bob, what are you talking about? He's like, well, you'll take on the Centers for Disease Control and Prevention. You'll take on the National Institutes of Health. You'll take on the Assistant Secretary for Preparedness and Response, the Strategic National Stockpile, and you'll work more with the Assistant Secretary for Health, Admiral Brett Giroir, as well as the Surgeon General in the Public Health Service Corps. But again, well, it's not going to add too much to your work. These has traditionally been light lists when it comes to legal work. I said, okay, sure, Bob, I'll do whatever you ask. Happy to serve the nation. Well, you guys probably know what happened next. These portfolios were not sleepy, to say the least, and the world changed. Came January. Fast forward, the first crisis we were dealing with at the agency, once we got past the initial repatriations, the quarantines, cutting off travel from China, then other parts of the world, and figuring out how to repatriate Americans back from Wuhan to the United States, and then those off of various cruise ships like the Diamond Princess, and dealing with quarantine issues that have not been dealt with in this country ever, mass repatriations and quarantines to the scale. We dealt with our first national crisis after that, which was visibility. We did not have the visibility we needed through proper diagnostic, through cost-effective diagnostic, through widespread diagnostics across the nation. Next slide, please. So with that, the administration turned to the pharmacy community. Remember in March, the announcement on the Rose Garden lawn, the president announced that shortly there would be drive-through free testing sites across the nation in socially vulnerable communities, teaming up with some of our country's largest pharmacies and labs and other companies. I can tell you, I was actually sitting at Independence Avenue in my office at HHS when I saw this announcement on TV on CNN, and I thought, wow, that's interesting. Wonder how they're going to do that. And we already have this great partnership and infrastructure in place, Ready, Set, Prep, working with so many of the nation's pharmacies, and we have such great contacts. This is a great idea. And as I was thinking of that, my phone starts ringing. It was from the White House saying, Will, we need you and your team, your legal team, to support the operators and our public health experts to work with these companies to start scaling up this testing environment. Well, I'm like, well, that's quite interesting. And then next call was from one of these major companies. Next call was from another one of these major companies. At that point, I stopped picking up the phone. I walked down to Bob Charo's office. We walked down the hall to Admiral Brett Giroir's office, to Deputy Surgeon General Rear Admiral Eric Schwartz were there. And then it became the next 72 hours, no one left HHS working to solve these issues. And among them was how to provide legal protection for all those who are stepping up to help this nation, to work with the federal government, provide more visibility through surveillance, through testing when we need it the most, when we're in such uncharted territory where the lawsuits can come out of any angle, right? We need to give our private partners comfort that if they do what the federal government is asking them to do, that they will not face legal consequences. So as we were flipping through the Public Health Service Act, we looked at the PrEP Act. The PrEP Act was actually designed for this very purpose. For those of you who are not very familiar with the PrEP Act, I don't plan on jumping into the legal nitty-gritties of it. But suffice to say, the primary purpose of the PrEP Act is for situations where there is a public health emergency or credible evidence that there could be something that could become a public health emergency, and to really protect those who are stepping up with a public health response and giving them broad immunity from lawsuits, from those who might be who have a complaint that, you know, a therapeutic that was issued or a brand new test that was being administered did not catch or yielded a false positive or false negative, and that led to bad health outcomes. It's to protect against that type of uncertainty, especially when we're dealing with a fast moving situation in uncharted waters with a novel coronavirus where the science was literally changing every day. That type of legal uncertainty without this type of protection would deter others, many others who otherwise would step up or unfairly penalize folks who are just trying to do their best following sometimes conflicting public health instructions or evolving public health instructions. So that was the genesis of PrEP Act Declaration, which was issued on March 17th, 2020, to support the whole of nation response, and particularly to support the most urgent effort at the time, which was to roll out a national testing in our socially vulnerable communities where people can just drive up and for free get tests. This was happening at the same time in parallel with our efforts to address supply chain disruptions, whether it was personal protective equipment. Of course, we needed respirators, we needed gowns, we needed face masks, we needed medical gloves across the nation, and particularly at these testing sites, and we needed swabs and media. And so it was born from that Project Airbridge and collaborations with major distributors and other medical supply companies to bring in the supplies that we needed to support these testing efforts and other efforts. So that community-based testing site effort, the public-private partnership, was underway. And then the second issue the federal government faced was, okay, this is doing well, but we need more. Not just in socially vulnerable communities, but across the country. What are the bottlenecks? Well, we were already dealing with one of the bottlenecks, supply chain, but the other bottleneck was folks and access. We needed to make it easier for Americans to be able to access COVID-19 tests, because the easier the access, the more testing would have, and the more testing would have, the more visibility would have, and the better our ability to contain or at least slow down this virus until we developed better therapeutics and a vaccine that could offer a stronger response. So again, we reached out to our internal experts, medical experts, both nurses, physicians, and the pharmacists within HHS. And we also, we at HHS, and the medical teams and legal teams also reached out to the various pharmacy stakeholders and other stakeholders in the medical community. Again, the answer came back to what we knew when we were looking at the HIV and in the HIV epidemic strategy, which is we needed accessible not just in terms of location, but accessible in terms of convenience for hours, especially as other settings for medical care were closing down, especially as folks didn't want to travel as long distances, especially as when convenience was especially important, because we didn't want people congregating in certain limited hours. So the longer the hours of availability, the better it was for our testing response to not create environments where COVID could spread more easily. And the answer was obvious to us. It was America's pharmacies. 90% of Americans living within 5 miles or less of a pharmacy, data that we knew back when we were building the HIV apparatus for distributing and engaging patients, flexible hours, extended hours. And as much of our nation was shutting down, our pharmacies, they kept their doors open, becoming often the only point of care for patients, both for COVID and for their continuing medical needs and for other emerging medical needs. But the second problem we dealt with then was state scope of practice laws. That was a patchwork back then. In some states, pharmacists were allowed to order and administer and collect specimens. In other states, they weren't. It was a patchwork across the nation. So in a time when a whole nation response was absolutely critical in a time where the science has already proven to us that the virus did not care about state borders. We were looking for a tool to really break down that barriers so that no matter where a patient was, they could access their local pharmacy and obtain a COVID test as easily as possible. Because we're sort of dealing with a chicken and the egg problem as well, right? Would pharmacies invest in the infrastructure, in the PPE, in getting the tests and forming the relationships with diagnostic labs until they knew that the authority to administer these tests and to collect the samples were there, or vice versa? So we decided to move at the same time. And again, there was no established authority that HHS had ever used that anyone had been aware of up until that point that could preempt state scope of practice rules, because that's how our nation and our public health legal structure is built. Healthcare primarily is local. State boards of pharmacy, they control state scope of practice rules. And that is the way it has been. And there had been no exercise in known legal authority that HHS had ever used for this purpose. So again, the legal team, and I had the privilege of working with some really just dedicated, smart, and creative attorneys. We sat down and we looked through the entire Public Health Service Act. We looked at CDC authorities for pandemics, quarantine, emergency authorities, but we came back to the PrEP Act. And the PrEP Act had this really interesting provision. Remember, everyone was looking at the PrEP Act and thinking, look, the PrEP Act probably couldn't help here because it was designed to protect individuals and companies from being sued when, it was a liability protection provision. But without getting too in the weeds for legal, in the legal weeds, there's a really interesting provision that allowed the secretary to designate individuals that could receive this type of liability protection. And when it designated, the statute designated those individuals, it designated a category. That category 1 was anyone authorized under state law to do whatever it is related to the pandemic response for which that individual would receive liability protection. And then category 2 was any other person the secretary deems should receive the liability protection. We looked at that, and we're like, well, yes, this statute is only a liability protection statute, but when Congress wrote that the secretary can designate anyone else other than someone who is authorized under state law to receive liability protection, that statute would have no meaning and no effect unless the secretary can also designate someone who is not authorized under state scope of practice rules to engage in that act in the first place. And then you scroll down the statute, and the statute says any requirement under the statute, under the PrEP Act, that is different from or conflicts with state law would preempt state law. And with that, we're off to races. And HHS issued some of these things that you see on the slide before you. Guidance, advisory opinions to give the pharmacy community across the nation comfort that the legal authority would be there, notwithstanding any state scope of practice restrictions. Interestingly enough, HHS was never sued for the position it took, which probably reflects an understanding that the legal position was very sound. There was some pushback in very few, well, actually 1 state and 2 territories. But at the end of the day, HHS was able to work out solutions with them, and it did not come to a lawsuit. And in fact, many states pointed to the HHS PrEP Act advisory opinions, authorizations, as a basis for expanding their own state scope of practice rules to be consistent, because they've also recognized not only was it legally sound, but to respond to this pandemic, we needed to really unleash and empower our pharmacies across the nation to join the other stakeholders to respond to this public health emergency. As a result, by June 30th, not only were pharmacies across the nation already performing COVID-19 tests, the HHS partnership with both chain pharmacies, mass merchant pharmacies, grocery store pharmacies, as well as independent community pharmacies had grown to most states performing hundreds of thousands of tests for free in socially vulnerable communities. At this point, I can tell you one of the really emotional moments. There were many of them. There were many moments when the team at HHS were just so inspired, and there were tears. Where after in the wake of the tragedy with George Floyd in that summer of 2020, in the heartbreaking events that occurred across our nation. And then for those of us working on the community-based testing sites efforts, so many of the pharmacies had to shut down after some of the social unrest and civil unrest that resulted in property damage. And I still remember some of them. They opened up the next day. I mean, and the closest community pharmacy to HHS that was participating in community-based testing sites was Dr. Michael Kim's Grubbs Pharmacies. I still remember he was in communication with the Rear Admiral and our team. And one of the evenings late at night, one of his pharmacies was completely destroyed, not completely destroyed, but experienced massive pharmacy damage. A truck was actually driven through the front of one of his pharmacies. This was covered in news media outlets, and it was so inspiring and a shot in the arm for the rest of us to see that the very next morning he had reopened up. Him and his team had just worked throughout the night to be able to continue performing tests the very next day. And we saw this across the country. Next slide, please. We continued, the second bottleneck that, we continue to see as a nation was in the hotspots where COVID outbreaks were just uncontrolled and were taking a toll on our most vulnerable members, our elderly who were in long-term care facilities. But a problem that we had was a lack of sufficient PCR testing, which was the most accurate testing across our nation. But we did have as a nation more antigen tests and rapid response testing that we could send across the nation. But the problem with these tests were that they were not as accurate as PCR tests, and sometimes that they would yield false positives. So this was when the PrEP Act was used again. And this really shows that, the government was able to pull together, not just with the public health divisions, but also working with the FDA and CMS and CLIA to say that in this situation, yes, we know that the antigen tests were not approved for asymptomatic individuals and for screening, but there's a huge need. In light of the shortage in congregate care facilities where PCR tests are not available, we created temporary authority to allow the use of rapid testing to test more than once, to test more regularly, to ensure that we're able in our congregate care facilities, we're able to identify cases, including asymptomatic cases of COVID before they wreak more havoc and cause more hospitalizations and deaths. And so that was issued in August of 2020. Next slide, please. And this was our only instance in which a state initially came to odds with HHS over use of the PrEP Act. And this was covered very prominently in the New York Times. And I could assure you, this is the only instance in the history of the New York Times where the PrEP Act received front page coverage. Nevada first ordered the halt of all these rapid tests, citing the false positives, without getting into a debate of whether that was clinically accurate I mean, that's not my expertise. Admiral Giroir stepped in and reasserted the PrEP Act as the basis of pointing out that Nevada's actions were illegal. And then shortly after that, Nevada revoked its position in the antigen testing for screening purposes in congregate facilities where PCR testing was not widely available, was able to resume. I know that Admiral Giroir has said this publicly, so I don't mind sharing it. He strongly believes, as well as so many public health officials at HHS and outside of HHS, who believe that this action, in the light of the death and hospitalizations we're seeing out of our congregate care facilities and the shortage of testing that we were experiencing as a nation, saved lives. Next slide, please. Now, during this time, around the same time, we were seeing a potential second public health crisis that we as a nation could ill afford. In May, the CDC issued a study that showed a dramatic drop in childhood vaccinations as a result of the COVID pandemic, as a result of the lockdowns, as a result of parents hesitating bring their children to the pediatricians or their primary care physicians' offices for their child visits because of the fear of exposure to COVID and desire to just stay home, or the hesitancy for those who do not have access to private transportation to use public transportation at the time. At the same time, some physicians' offices were closed or had less availability than they normally would have. So the question was therein again, what can HHS do about it? What can we as a nation do about it? Because we knew this problem needed to be fixed, it needed to be turned around. School season was starting very soon. We're going into the fall. The last thing we wanted was a spike in other diseases that is preventable, have been prevented, and can easily be prevented by childhood vaccinations while we're still in the midst of another wave of COVID. The answer again was pharmacists. And we did this with, a lot of careful deliberation, speaking with many members of the healthcare community, pediatricians, primary care physicians, and the pharmacy community. This was when I first met Mitch Rothholz, because I remember my team and I were looking for real data and survey of what have the states been doing? Because let's not try to reinvent the wheel here. We know that in many states, children can receive their vaccines at pharmacies. What have they done? What type of vaccines? What are the age cutoffs? We were looking for, data out there that actually had looked at this issue before and collected it all together, so our legal teams can also go then and go state by state and look at their statutes. Well, Mitch Rothholz's name came up repeatedly in Google because apparently him and his teammates have looked at this issue extensively. And this was not the first time I did it. It wasn't going to be the last time my team and I did this, but I cold called him. And Mitch was very generous of his time, spending a lot of time, sending a lot of resources that saved the HHS team a lot of effort and many hours, surveying the state laws. And the question we kept on asking was, we're looking at this patchwork, across the states. Some states said yes to childhood vaccinations, but only for 3 years and older, 5 years and older, 7 years and older. Some states limited to certain vaccinations, not other vaccinations. Some states had no children, only 18 and older, and other states had no restrictions whatsoever. And I kept on asking the question of the HHS pharmacists, like Rear Admiral Ty Bingham, like Admiral Krista Pedley, who are all trained pharmacists, and the other pharmacists in the Public Health Service Corps. Why is there this patchwork? Is there a medical reason for this? And the answer was no. It's just the vagaries of, it's just how things have developed over the years. And I got the same answer when I asked private stakeholders as well. And so where the public health professionals at HHS landed, including Admiral Giroir, including the secretary, and including Dr. Redfield, the CDC director, of course, the CDC leads the Vaccines for Children's program, was that during this time when we need a whole nation response, we need to take care of this patchwork. We need to unleash and make available as many avenues for safe, effective, and easy access to childhood vaccinations as possible. And therefore, the PrEP Act was exercised again with the Third Amendment on August 24th that expanded access to childhood vaccinations to all pharmacists for children of a certain age and older. And we at HHS and the policymakers were certainly very sensitive to those members of the medical community who might have a different view. And that was also captured in the Third Amendment, as well as in Admiral Gerard's and Secretary Azar's public statements about this, which is recognizing the importance of the country's pediatricians, the importance of not missing a wild child visit. So as a requirement for pharmacists to enjoy and to use this authority on the PrEP Act, that PrEP Act amendment actually required the pharmacists to use their best efforts to inform care guardians, parents and other guardians of the children who came in for vaccinations of the importance of seeing their pediatrician or other primary care professional, and to ensure that the child does not miss the wild child visit, and to make referrals as appropriate. And the idea is really simple. This is not an either or. It's not that if pharmacy wins, other parts of the healthcare system loses. We can all win together. And remember, we all win together if the patient wins. And we were really, driven to that conclusion based on a couple of things that we saw. One was experiences out of Georgia, where as part of Georgia's authorization under their state practice for pharmacists and vaccinations, we actually saw the form that Georgia uses that has Georgia pharmacists to assist patients and their children and their caregivers with referrals to pediatricians and other primary care physicians to promote children to be in a medical home, to be part, to not miss those wild child visits. That was number one. And number two, we actually found a study that was spearheaded by by the HHS Public Health Service Corps and within the Indian Health Service system that demonstrated that when pharmacy technicians were actually brought into the certain communities and the IHS system, not only did those communities see an increase in child vaccination rates, they also saw an increase in children and families who were put into and were a part of that pipeline where the children were receiving their wild child visits and were part of a medical home. So it was a win-win for all. So that's how the secretary and the public health experts designed the Third Amendment, to really reinforce that message. We can rise as an entire healthcare community when we put the patient first, and the results and better clinical outcomes for the patient first, and we coordinate and collaborate together. Next slide, please. What folks, through the HIV, ending the HIV epidemic and Ready, Set, PrEP, and then testing, and then child vaccinations and every other effort, the message we at HHS received from stakeholders over and over again was the answer needed to have two components. One is, can the pharmacist and the pharmacist tech and the pharmacist intern do something? That's the can part authority. But that's only half the picture. After the can, there is how, and how requires money behind it. For the ending the HIV epidemic, that in part was taken care of because of the generous donations of the pharmacies when they came and donated their dispensing services. And of course, Gilead had donated the therapeutic in the first place. When it came to the community-based testing sites and the public-private efforts, there was appropriate funds that were allowed for direct reimbursement through that program. But the question remained. Those are limited programs. There needed to be broader funding. Well, we all know here on this call that Medicare has not recognized pharmacists for the most part, with certain categories like mass immunizations and roster billing, some limited immunization categories. But Medicare does not have a broad provider recognition under Part B for pharmacists. And Medicaid and CHIP, we want to see how funding could be opened in those programs as well. And then on top of that, there's a Vaccines for Children program. In order to administer these childhood vaccinations, one would need to be enrolled on not just in Medicaid, but also for Vaccines for Children. And all these statutes had something that we noticed was very interesting. These statutes governing Vaccines for Children, Medicaid, and CHIP tied the ability for enrollment and to receive reimbursement to, among other things, whether that practitioner was authorized under state law to perform that service. So again, a novel question arose, right? What happens if the state law says no, pharmacists are not authorized to administer a particular vaccine to a 4-year-old? No, a pharmacist cannot order and administer a COVID-19 test, but the federal government through the PrEP Act had preempted that law. In that situation, would the pharmacist be qualified to enroll in Vaccines for Children? Would the pharmacist be qualified to enroll in Medicaid for purposes, in CHIP for purposes of receiving reimbursement? So again, the legal brain trust at HHS, such as it was, got together. We had the benefit of really, mission-driven, smart, principled attorneys, not just at HHS, but also received great support from across the federal government and the smart attorneys there. And we announced the position that for purposes of CHIP, Medicaid, and Vaccines for Children, that when the PrEP Act preempts state law, and for purposes of those programs, a pharmacist who is authorized under the PrEP Act to perform those services is also eligible for enrollment in Vaccines for Children and to receive reimbursement under CHIP and Medicaid. Next slide, please. With that chapter over and with some funding sources open, we had our eyes forward to the urgency of Operation Warp Speed. I mean, Operation Warp Speed had already been running on therapeutics and, of course, speeding our developments appropriately, of course, by streamlining processes, by running processes in parallel, by providing government funding to de-risk much of the activity that the private sector would traditionally bear, which in turn would lengthen the process for developing therapeutics and vaccines. That was moving at a really great clip, and a number of options were showing promise. But of course, again, the question was, developing and having a vaccine is great, but just like PrEP with the HIV medications, just like so much else, we need a way to make sure it gets to the place where it's needed the most across the nation with accuracy into settings that are not only accessible, but has folks that our communities trust. Because HHS knew, CDC knew, NIH knew, the Office of Assistant Secretary for Health knew that vaccine hesitancy was going to be a problem. And the number one solution to that problem was having trusted healthcare professionals in that community being the ambassadors for these vaccines. So with that, the efforts were underway. By that time, they were already fully underway to build an infrastructure that included our national chain pharmacies, our independent community pharmacies, our small regional chain pharmacies, and then across multiple settings of care too, whether it's your grocery store or mass merchant, or in some cases in mobile units, or bring the vaccines to folks' homes. We knew we needed, once again, the nation's pharmacists to step up, and we knew that they would, and they did. So began, and many of you, the folks on this call, were on those meetings that occurred once, twice, 3 times a week at 1 hour, 2 hours at a time, to make sure that these pipelines were set up. So when the authorization was received, there would be seamless delivery from the manufacturer to the distribution centers, to the points of care, into our pharmacies where shots can go into arms immediately. And so with that came again the authorizations through the PrEP Act. We as a country at that point had a tried and true method to use the PrEP Act to open up these avenues, to open up these sources of not just pharmacists, but pharmacy technicians and pharmacy interns, to make sure that as many immunizers as we needed would be available where the patients were. And with that, we, HHS also worked with Congress, worked with colleagues at the Department of Labor, as well as the Treasury, to ensure that reimbursement would be available broadly, whether it's Medicare, Medicaid, private insurance plans, that no patient would pay a single cent out of pocket for the COVID-19 vaccine, not just for the vaccine, but for the administration. It sounds like an easy place to reach, but I guarantee you it was a very complicated statutory, regulatory, and just a logistical system to stand up in a very short period of time. For HRSA to build up a portal that, needed improvement and was continuously improved, to be able to provide seamless or, less clunky pathways for reimbursement for our pharmacists and other providers to obtain coverage for patients who were uninsured, as well as to collaborate and work with the nation's commercial insurers to make sure that there's those pipelines all available, so every patient can just walk into a pharmacy and get the vaccine and not have to pay a single cent out of pocket. That was effort, and it could not have been done without the valuable input, again, of the pharmacy community. Explain to us what works at the pharmacy counter in terms of something that can act that would not conflict or would minimize interference with the workflow, so they could spend most of their time, less time on the reimbursement aspect and more time in handling these vaccines, working with patients, dealing with vaccine hesitancy, and then putting shots into arms as we fight this pandemic. So that was the PrEP Act, again, stepping up, opening up those avenues. Now, a big question, as we moved into January, as the vaccines started flowing at the end of December, and then started ramping up really quickly in the beginning of January. I think even before January 20th, the nation had reached over 1 million vaccines administered a day. Was what would happen with the next administration? There were, yes, what this administration, with the input of the healthcare community had done, the PrEP Act, it was effective, it was popular, but it also had naysayers. It also had those who were concerned that the PrEP Act would provide too much liability and immunity. And there were voices in various stakeholders who wanted a narrowing of the PrEP Act. So we look into the new administration, and very happily, the Biden-Harris administration continued down the same path, pointing to the same playbook with preemption, adopting the same legal doctrines, and expanding it even further to physicians, pharmacists, nurses, dentists, midwives, even those who had expired licenses, but it was recently expired and they were still in good standing. So the PrEP Act played a large role in our nation's response to COVID, and most recently in September 2021, the Biden-Harris administration, through Secretary Becerra, issued the 9th Amendment, which opened up the ability of pharmacies to order and administer FDA-authorized therapeutics for COVID-19. Next slide, please. Let's move one more slide. So the question is, what next, and how do we, approach the learnings of, the last 2 years, and to maintain the ability of our pharmacy community to continue supporting our way out of this pandemic, but also help prevent the next pandemic and to address this myriad public health crises that we continually face: the opioid crisis, the HIV epidemic, chronic conditions that has, really exacerbated hospitalization and death tolls in in this country. So there's three different avenues that we had to look at: state, federal regulatory, and federal legislative. I can't predict the future, but I would not recommend the pharmacy community to depend on the PrEP Act to indefinitely preempt state scope of practice rules. And one need not look any further than the PrEP Act declarations and amendments itself, which emphasize repeatedly that the need to preempt state law is tied to this unprecedented global public health emergency that requires a whole of nation response. When the public health emergency is over, and when even after that, the credible risk of COVID resurging is over, one cannot expect that the state scope of practice preemptions will remain in place. So in line with that, I strongly encourage this community and all the associates on the line to think about ways, laying the groundwork now, laying the case that what the benefit that the pharmacy community has brought to its communities within each state through the pandemic, not just for COVID, but increasing childhood vaccination rates, increasing other access to therapies, improving medication adherence. Those are things that would benefit states, their Medicaid funds, and other expenditures on a moving forward basis. And for using that data to encourage states to relax or maintain the state scope of practice expansions that many states or some states via the PrEP Act has put in place for this pandemic. That's number one. Federal regulatory, this is where I'll focus on the payment aspect. In 2020, HHS finalized its rules on value-based care that allows pharmacists, other stakeholders, hospital systems, physicians' offices, even social workers to form value-based care arrangements that could receive bundled payments that organization could share within that enterprise. That before, in the absence of Part B recognition and payments, that provides a vehicle for pharmacists to expand their practice beyond what they're doing now, and most importantly, to receive payment to support what they do. But again, it requires collaboration. And that's something that those rules were meant to encourage: collaboration and better care coordination around the ecosystem. The third regulatory pathway for receiving payment is through the Affordable Care Act and the demonstration models that the Innovation Center at CMS can provide. And again, I suggest the agency has repeatedly made clear that the future that they're looking at is more value-based care and more care coordination. So when approaching CMS for these type of models, which can waive any requirement in the Medicare statute, including provider status requirements, which in turn can open up payment for pharmacists, think about bringing data, think about bringing value, think about bringing coordinated care models to CMS so they can understand how these care coordination models can improve outcomes for all. And I'll just give one example of the type of thing that can really resonate when approaching CMS. In January of this year, the National Institutes of Health had a study that was released. There was a collaboration led out of Duke University, and it was a collaborative model involving primary care physicians and community pharmacists in Raleigh, North Carolina. The study was funded by the National Institute of Health's Institute of Drug Abuse. And these researchers, they enrolled participants who were experiencing opioid use disorder for management of opioid use disorder therapies and medications, including buprenorphine. And what this study demonstrated was that when there was that type of care coordination between the physicians and the pharmacists, nearly 89% of all these patient participants remained, and there was a 95% adherence rate to their daily medications, daily medication schedule. 95% adherence rate. That is tremendous. Collaboration, care coordination models such as this directed at pressing public health crisis that this nation is still facing, that is a priority for this Biden-Harris administration and HHS, are going to be very powerful methods of engagements with HHS if we are to continue to press for regulatory flexibilities, not just in authority, but very importantly, in payment streams for the work that the pharmacy community does. And I know we're running short on time, but the last point I will raise is data, data, data. You know, I can tell you from being on the inside, so many of the policy, even if the pharmacy community were to find champions within the agency, at the end of the day, arm those champions with real world data that supports their case for funding pharmacists and performing what we all know are essential and really advantageous tools in our nation's public health arsenal. Data is what separates optimistic notions from achievable solutions, and that's also what your champions in the government will need in order to pass OMB, in order to pass all the other stakeholders to demonstrate that the investment is worth that the expenditures are worth the investment. So I'm going to end the talk right now, move into Q&As with, again, gratitude to so many of the folks on this phone in the pharmacy community, what they have done for this nation. Thank you.
Yeah, thank you so much. And I'm going to ask folks to raise hands, and I see Becky at NASPA is already compliant. So Becky, if you could ask your question, please.
First of all, Becky Sneed with the National Alliance of State Pharmacy Associations. So that patchwork that you speak of, we live and breathe every day. Well, your leadership has been amazing, and I just need to thank you. I have two questions, and I understand we're short on time, so I'll be very, very brief. The first is, can we use all of your quotes? You have amazingly offered in today's presentation, but seriously, the two areas is the Vaccines for Children program. We welcome the opportunity, and we're so excited to be able to increase the vaccination rate in children. And we are working really hard to have state laws mimic that, so that after the PrEP Act is no longer in effect, we can continue to do that. But participation in the Vaccines for Children program, where we have less than 100 pharmacies across the U.S. that are currently enrolled, you know, we've got to break down those barriers. And so any guidance you can provide there, not necessarily today, would be greatly appreciated. The second area is with the Ninth Amendment. Pharmacists are really ramping up to try to increase access to monoclonal antibodies. But what we're seeing is not on the Medicare side, but barriers with state Medicaids in authorizing payment for the administration of those vaccines, as well as barriers with commercial payers implementing stops if you're out of network, and or for not honoring first dollar coverage. So there's huge copays and deductibles. In fact, you know, sometimes exceeding the cost that it would be, you know, that you would receive from Medicare. So any guidance you have as far as what we can do with the Ninth Amendment to help improve access within our Medicaid recipients and our commercial patients. So again, maybe more than you can handle today, but I welcome the opportunity to follow up with you to get your ideas.
Absolutely, Becky, and I'm happy to follow up with you separately as well. Just want to remind folks, I'm no longer with HHS. I'm in the private sector right now, but two high-level observations. The solution to what you are asking for is, again, going to be in the policy realm. Legally, what the PrEP Act does is it removes state scope of practice as an eligibility criteria to receive Medicaid reimbursement, but it doesn't say states, you must now enroll them very quickly and start the flow of money within the next week, 2 weeks, month. And I could tell you at my time at HHS, when this issue came up with childhood vaccinations, the answer that HHS received from states was that they were so backlogged in the Medicaid programs, resources were stretched, and they were doing the best that they could. So I don't have a good answer for you for that. I mean, I don't know how to break the shortage of personnel bottlenecks in states. I know that those partners are working extremely hard.
Okay, and our next question is from Lucinda Main at AACP.
Thanks, Will. I've been in the profession for 40 years and I've never heard a presentation as compelling as the one that you've just made. So I echo Becky's kudos to you for a superb presentation. At the very end, you were talking about the importance of data, and no one would argue against that. I'm wondering if you know within the current administration and structure within CMMI, who the best points of contact might be. I'm aware of at least 2 investigators right now who have the methodology spelled out for a compelling multi-site piece of research that addresses all of the issues that you've just teed up for us. But I'm not sure they know who within the current administration is most accessible and interested in this kind of work.
Yeah, I'm happy to also continue this conversation in more detail later and brainstorm, but I would actually point you to Mickey Tripathi at Office of National Coordinator. I mean, he has in his public statements really made clear that he is hungering for more public health data to as a basis to tackle health disparities. And so let me connect the dots for you there, because I believe this based on anecdotal data I have and some limited data that I have, which is that our pharmacies are, I mean, they're going to be an indispensable tool to address health disparities across the nation, particularly in medically underserved communities, no matter what we're talking about, whether it's diabetes, whether it's hypertension, whether it's vaccination hesitancy, whether it's childhood vaccinations. The tragedy of our country's healthcare is that it varies by zip code, and we see wide variations across race, and many of that is tied to access issues, right? And as we all know, our pharmacies are among our most accessible. And it's not just location, it's not just transportation barriers, but it's the hours. I remember growing up as an immigrant, on Long Island. My father worked for New York Transit Authority. My mother worked at the local public library. They couldn't take time off in the middle of the day to take me to a pediatrician. I got my vaccinations at the local pharmacy. So that's why I think this is the answer. If you look at what the Office of National Coordinator is doing, the data it's asking for, what's doing interoperability, what's doing information blocking, and the hunger and its request that please feed us the data that could help us shape policies about sharing data, collecting data, and using data, particularly to better coordinate care and to narrow those health disparities. I think that's an office that is that would welcome these type of dialogues that's data driven, and not just data that we can bring to the table, but also request that here are the barriers for us to collect, disseminate, and use these data. As we can do so in a way that both improves outcomes and continues to protect privacy. That would be a welcoming audience for that type of conversation as well.
Thank you. Well, I think we got time for one more question. It looks like Brian Caswell, the president of NCPA, and I would like to point out that Brian made a fantastic statement to the FTC on the perils of vertical integration related to insurance, PBM, and pharmacy mergers. So, Brian, you have the last question.
All right, thank you, Scott, and thank you for the compliment there. I appreciate it. I just want to echo Lucinda's comments as well, Mr. Chang. It's a great presentation, very well put together, and I was hanging on every moment, and I can't say that about all presentations, it seems like, as we go through. But first off, I want to say as a representative of my community, we are extremely grateful for your efforts in providing access to vaccines and testing into our communities, despite all of the barriers, logistical and political. So it was not easy, and we are being called heroes in our communities for what we're doing. There are heroes beyond our practice and what we're out there from the front line aspect, and you're a representative of one of those. So thank you again for your service, and thank you from my community. This last weekend, I was at a State Pharmacy Association meeting. I visited with the executive director of the State Board of Pharmacy, and I asked her, about, when the PrEP Act finally goes away, how much of what we've been able to utilize to address the issues and needs for our community, how much of that we think you're going to be able to retain? And she said, probably none. And so that was disheartening to me. She said, I think you're going to have to work at a federal level. So, and I know you've given us some ideas already. I just wonder if there's any more avenues that you think that we could do, perhaps at a state level that's not been tapped into yet, or maybe a multifaceted approach of going to federal and state to see if we can maintain the access to all these issues that we've had, and keeping pharmacy in the forefront and accessible, healthcare needs that needs to be addressed for our community.
Brian, thank you for the much too kind words. I first want to say I had a fantastic team and fantastic clients at HHS, like Admiral Gerard, Secretary Azar, Director Redfield, and fantastic teams over at CDC, NIH, and just brilliant lawyers, committed public servants. And of course, we had the benefit of your expertise and expertise of this community to make sure that we weren't doing something that was counterproductive. And second, to your question, I agree it has to be at least a three-pronged approach that's at the state level for scope of practice, federal regulatory for some payment avenues, but for broader permanent payment avenues, especially in Medicare, it's going to have to be in the legislature. Having said that, there doesn't mean there are targeted approaches. I've talked about some of them, but there are others as well that still involve the PrEP Act. Remember, when the Secretary invokes the PrEP Act, there needs to be, there's two primary considerations. One, is there a public health emergency or credible evidence that there will be a public health emergency soon? So the PrEP Act's flexibilities is needed to avoid that public health emergency. And two, does the nature of that emergency merit such broad liability protections? Recall that prior to this pandemic, no one has used the PrEP Act to preempt state scope of practice laws before. So I'll give you one example, and perhaps that can give you a springboard to other ideas. When I think about where the PrEP Act might be used after this, I think about a disease state that is, no question, a high priority in a public health emergency. Think the opioid crisis, think HIV. Then I think about a therapy that has a low risk profile. Because remember, if the government is going to provide liability immunity behind it, that means the government's funds is going to cover injuries. So they're going to think about how much this might cost, right? So low risk profile that pharmacists are uniquely situated to. So one that would pop to mind immediately is PrEP, pre-exposure prophylaxis. California and Colorado has already moved ahead with it on pharmacists making PrEP more available to those who are at risk of HIV. There's no reason why HHS, particularly given that Indian HIV epidemic continues to be a high administration priority, cannot be invoked under the PrEP Act. It's already an epidemic. It's already an initiative. Using Truvada and Descovy, relatively speaking, and I defer to the FDA label, so I don't want to run foul of those, it's a pretty low risk profile. So think about different avenues that check those boxes. And I think that provides a very fruitful path for engagement with HHS.
Well, Will, thank you so much. And I'm not generally safe or comfortable doing this, but I feel very safe and comfortable speaking on behalf of all of the organizations here today with a huge thank you for your advocacy related to this and for a fantastic presentation. So thank you very much. We're now